So this is the classification of different types of bone defects that you see in periodontal lesions. Okay, this classification was given by Goldman and Cohen. The classification is given by Goldman and Cohen. Very important. In every lecture, all classification, all important authors I will put forward like this as one point, because many times you get a question on them. Who gave this classification? Okay, so please make a note of this. When we go into your live classes, make sure you by heart all these authors. The important ones we will always put forward. Okay, now coming to the defects. The first one we have is a supra-bony defect. Supra-bony defect. So what do you mean by this? Let me draw and show you what do you mean by supra-bony defect. This is the bone, and let me draw the periodontal tissue. This is your pocket that has formed here. Okay, this is known as supra-bony defect. What is the other name for supra-bony defect? It is also known as horizontal bone defect. It is also known as horizontal defects. Now, how do you define this? You can define it two ways. In relationship to the bone, you can see that the bone will be perpendicular to the root surface. The crest of the alveolar bone will be perpendicular to the root surface. Or you can say that the base of the pocket will be always coronal to the crest of the alveolar bone. The base of the pocket, the base of this periodontal pocket is coronal. It is situated at a coronal level as compared to the crest of the alveolar bone. As compared to the crest of the alveolar bone. Very simple. That is your supra-bony defect or your horizontal defects. Okay, I hope that is clear. Now we will move on to infra-bony defect. So what is the other name for infra-bony defect? They are also known as vertical defect, or they are also known as angular defect. Okay, this classification you will not find in Carranza. This is taken from a textbook known as Linde. Okay, it's a one step higher, but this is the correct classification, which is for the bony defects. Okay, so infra-bony defects or vertical defect or angular defects. What are these? These infra-bony defects are further subdivided into two categories. What are those? They are subdivided into intra-bony. Remember, this is F, this is T. Infra-bony, intra-bony. So you have an intra-bony defect and you have a crater. You have an intra-bony defect and you have a crater. This intra-bony defect is further subdivided into one-wall defect, two-wall defect, three-wall defect, and sometimes you can see something known as combined defect. Okay, so you have supra-bony defect and infra-bony defects. Infra-bony defects is further subdivided into intra-bony defects and crater. Okay, and the last classification is inter-radicular defect. Can you tell me what is inter-radicular defects? What defects are we talking about? In simple terms, when we talk in dentistry, what is inter-radicular defects? Anybody? Anybody can tell me what do you mean by inter-radicular defects? What do you mean by inter-radicular defects? Yes, I got one. Very good, very good. Now answers are coming in. Yes, it is furcation involvement between roots. Very good. So here, what are we talking about? We are talking about defects or in the furcation area. When you see defects like this. Okay, when you see defects like this, when you see that the probe can pass through and through, then you say that it is an inter-radicular defects. And that is again subdivided or classified more. We will come to that. But this is the three major classification. Okay, this is the three major class. Is this clear? Supra-bony defects, infra-bony defects, and inter-radicular defects. Okay, this is first what you should get into your head. Now we will go into detail one by one. How do you differentiate among all this? Okay, so I hope the first major classification is clear. So what you need to know is supra-bony defect, infra-bony defect, and inter-radicular defect and inter-radicular defect. Okay, now we will see a clinical picture of all this. Okay, so this is a clinical picture from your textbook. Can you see the defect here? Okay, let me just Okay. Can you see the defect here? It's mostly horizontal in pattern. Mostly. This is your cemento-enamel junction and the bone is flat like this. Okay. Bone is flat to the tooth surface or forming. You can say it is forming 90 degree to the tooth surface. You can say flat architecture. Okay. Flat. That is your supra-bony defect. Then you see a defect here. You can see one. Okay. Let me change the color again. You can see one wall here. And then a defect going inside, which is surrounded by wall at every angle. Okay, so now here, what is the thing? See the base of the pocket, infra-bony defect. Let me draw it here. Infra-bony defect. Let me draw it here. This is the defect. This is the bone defect, and this is where the pocket will be. This is where the pocket will be. So what is here? The base of the pocket is apical to the crest of the alveolar bone. The base of the pocket is apical to the crest of the alveolar bone. When we studied horizontal, what did we study? If I draw horizontal here on this side and the pocket here, what did we study horizontal here? The base of the pocket is coronal to the crest of the alveolar bone. Okay, that is a basic difference. Or if you talk in relationship to the bone, the crest of the defect is at the same level as the crest of the alveolar bone. Same level as the crest of the alveolar. But in this case, look at the bony defect. The bony defect is again at a much lower level than the crest of the alveolar bone. So that is the basic difference between a horizontal defect and an angular defect. A horizontal defect and an angular defect, or supra-bony defect and infra-bony defect. Supra-bony defect and infra-bony defect. Okay, and then you have the, what is the last one? Inter-radicular defect. You have inter-radicular defect. You have inter-defect here. See, you can see the furcation there. So that is the inter-radicular defect. Is this clear? Supra-bony, infra-bony, and inter-radicular. We will now go into the details, but I just want to know that at least till this point, you know the difference between three types of bone defects: supra-bony, infra-bony, and inter-radicular defects. Can I get a yes if it is clear so that we can move on? Okay, very good. Very good. Okay, nice. Okay, so the basic stuff is over. Okay, now we are going into the discussion of each of this. Okay. Just move this a bit so that, yeah. Okay, so we already studied what supra-bony defects where the base of the pocket is located coronal to the alveolar bone. Coronal to the alveolar bone. Infra-bony defect where the base of the pocket is located apical to the alveolar crest. Apical to the alveolar crest. Now we come to the two different types of infra-bony defect. Which is the first one? First one is your intra-bony defect. First one is your intra-bony defect. What is intra-bony defect? Bony defect whose infra-bony component primary affects only one tooth. So it is a type of infra-bony defect, but it affects only one tooth. It affects only one tooth. I'll explain why we are saying like that. Okay. So we studied the subdivision of this. What did we study? 3-wall defect, 2-wall defect, and 1-wall defect. Okay. Now, what do you mean by 3-wall defect? Okay. So remember, in perio, we talk about preservation, try to preserve everything. So we are talking about what is remaining or what is being preserved after the bone has resolved. Okay. So 3-wall defects means it is a number of walls that is remaining after the defect has occurred or after the lesion has occurred. Okay, so 3-wall defect is the number of walls that are remaining. Number of walls that are remaining. Okay, so there was a problem. Okay, so 3-wall defect meaning it is a number of walls that are remaining in the defect. Okay, now I'll show you what I'm telling you. Okay, so first one is the 3-wall defect. So first, according to our definition, what does an intra-bony defect says? It affects only one tooth. So this is the tooth that is affected. Okay, this is the tooth that is affected. Now we are going to study about 3-wall defect. So 3-wall defect meaning 3 walls are remaining. That means 3 walls are preserved. Remember preservation. So we are talking only about what is preserved. Many students towards the end of the exam, they tell me, so we get confused. Whether it is remaining or what is gone, we get confused. Remember P for preservation, number of walls preserved. Okay, so in 3-wall defect, you have, what is this? The facial wall. It is intact, right? This facial wall is intact. So 1 wall is present. Good. That is the first wall. Good. Then you have this wall that is present. What is that wall? Can anybody tell me the wall that I just colored? The wall that I just colored. Can you tell me which is this wall that I'm talking about? The wall that I just colored. What is that wall? Anybody? No, that is where, okay, that is where it is now the content. See, the mesial, very good. Dr. Sarasadevi, very good. Yes. Now what we are talking about is the wall which is remaining. What is remaining? See that there is a gap next to this tooth here. That means the wall mesial or the bone mesial to that tooth is already eaten up. What is present is something which is far away from that. So it is distal. So you have the distal wall which is present. And then finally you have this wall. Can you see this wall? This wall that is present. So 1 wall here, 2 wall here, and 3 wall. So you have the facial wall, you have the distal wall, and you have the lingual wall. 3 walls are preserved. So what defect is it? When 3 walls are present, what defect is it? We call it as a 3-wall defect because 3 walls are remaining. Okay, very good. Now let's move on to the next classification. That is the 2-wall defect. So now it becomes easier. That means there are only 2 walls remaining. Can anybody tell me what are the 2 walls that are remaining here? This wall here and this wall here. Which are the 2 walls which are remaining here? Which are the 2 walls that are remaining here? It's not the facial wall. Facial is what facing towards us. Yes, it is the distal and lingual wall. It is the distal and lingual wall. So only 2 walls are preserved. So you call it a 2-wall defect. Which all walls did we lose? We lost this one, the facial wall, and we lost the mesial wall. Okay. And then coming to the final one, that is the 1-wall defect. What is very simple. There is only 1 wall remaining. Which wall is remaining? Which wall is remaining? Very good. Somebody has put lingual. Can you see a gap there? Lingual is gone. The lingual is gone. Only 1 wall is remaining. That is the distal wall. Now, why I'm stressing importance is imagine if the distal wall was also gone. If the distal wall, this was also gone. Is the bone defect affecting only 1 tooth or does it start affecting the other tooth also? It will start affecting the other tooth also. Then it becomes 2 teeth. Then it becomes 2 teeth. Then can we say it is intra-bony? Intra-bony? No, we cannot say. So always the distal wall next to the tooth should be preserved. Then only we can say that it is an intra-bony defect. Then only we can say it is an intra. So here only this tooth is affected. See, this tooth's lingual wall is gone. This tooth's facial wall is gone. And this tooth's mesial wall is gone. Is that clear? So that is the 3 types of defects. That is the 3 types of defects. Okay. Now, sometimes in some situations, what happens is that one of the walls will be at a much lower level than the other bone level. See, the distal wall is here, the lingual wall is here, but the facial wall is resolved, but it is not resolved completely. That means in the coronal end, there is wall defect. The bone is eaten up. But as you come apically, suddenly you will find the wall here. Suddenly you will find a wall here. So in the coronal end of that tooth, you will have a 2-wall defect. Here it is a 2-wall defect. But when you come towards the apical end, it becomes a 3-wall effect. It becomes a 3 because now 3 walls are there. 3 walls are preserved. Little bit of the facial wall towards the apical end, the distal wall and the lingual wall. the distal wall and the lingual wall. Yes, I will repeat it again. I will repeat it again. Okay. So let me just clear this so that I can just go through it again. Okay. Okay. So what is a combined defect? So we are talking about combined defect here. We are talking about combined defect. So what is it? Nothing but it is a kind of defect where in the coronal portion of the defect, if we are talking about this defect as a whole, in the coronal portion of the defect, it's a two-wall defect. Because which all are the walls that are present? Distal wall and lingual wall. Facial wall, is it present at the coronal most end? No, it's eaten up or it has been resolved. But as you come apically of that defect, what happens? The facial wall is preserved. A little bit of the facial wall is preserved. So at the apical end of that defect, it becomes a three-wall defect. So it's a combination. At the top, it is a two-wall, and at the bottom, it is a three-wall. Okay, so that is why it is called as a combined defect. I hope it is clear now. It is called a combined defect. Okay, so now we studied three-wall defect, this one where three walls are remaining, two-wall defect where two walls are remaining, and one-wall defect where one wall is remaining. Is this clear? And then you have the combined defect. Two walls in the top at the coronal end and three walls towards the apical end. So there is a combination of two defects. So it is called a combined defect. Is this much clear? Different types of you don't get the walls. Walls are, see, imagine this is a three-dimensional. So this is just a pictorial explanation. This is a pictorial explanation. When I come to the clinical picture, I will explain it to you, how to identify it. You have to clinically see it 2-3 times to understand it. Okay. You have to clinically see 2-3 times to understand it. But it's a very simple concept. If you just look at this first one, you will be able to understand all the walls. You will be able to understand all the walls. See, the facial wall is intact here. Okay. This is the facial wall. This is the facial wall. The one facing towards us, facial wall. This is the facial end of the tooth. The opposite is the lingual. So the wall that is on the facial end, it is called the facial wall. Now this wall, which is present, that is away from the root. This is the root end. It is away from the root. So it is called the distal wall, away. If the bone was filled here, then this will be the mesial part of that bone. Mesial part of that. But that is not there now. That has been eaten up. That is eaten up. Okay. So you only have the distal. And the wall that is towards the lingual side, that is known as the lingual wall. So you have the facial wall, you have the distal wall, and you have the lingual wall. I hope this is clear. So when you come here, look at this. They have now what they have done. They have taken out the facial wall. They have taken out the facial wall here. The facial wall is not present. The facial wall is not present here. Only which all walls are present here? You only have the distal wall and the lingual wall. Just look at this picture and try to correlate. And then finally, in this one, okay, you can see a gap. Let me erase this one. You can see a gap on the back side of the tooth. See, there is a hole in this back side of the tooth. So means the wall from there is also gone. Which is that wall on the back side? That is a lingual wall. The buccal wall here is also gone. Only wall that is remaining is this distal wall. Only wall that is remaining is the distal wall. So that is how you get 3-wall defect, 2-wall defect, and 1-wall defect. Okay, I will show you the clinical pictures also, so you will get a better idea. Okay. So I'm erasing this now. So we are now done with the intra-bony defects. We are done with the intra-bony defects. Now moving on to next one, that is your crater. That is your crater. What is crater? Crater, it is a cup-shaped or a bowl-shaped deformity. Crater is a cup-shaped or a bowl-shaped deformity. Okay, somebody has asked me combined. Combined defect is what we discussed here. See, that means this is the whole defect as such. Okay, let me go back. Somebody still has a doubt. This is the whole defect as such. Now, just concentrate on this defect. Just concentrate on this defect. Can you see how many walls are there? This is the coronal end of the defect. The coronal end of the defect. Now here, there is one wall here in the coronal end and one wall here. Which is this wall? Who is the one who asked me? Shubham. Okay, Shubham, tell me which is this wall. Which is this wall that I'm drawing first? We just discussed. Which is this wall? Yes, very good. Which is this one? Just put the first letters. So for distal, you can put D, and for lingual, yes, you can. So you have distal and lingual walls that are present in the coronal end of this whole defect at the topmost. When we open the flap, the first thing that we see is that, okay, there is a bone here, there is a wall here, there is a wall here. So it is a two-wall defect at the coronal end. Now, as I open the defect more down, then I see that at this end, there is a small wall here. There is a small wall here. Okay, just like this. See, they have put two wall, one wall, two wall, and then a half of a wall here. So at the apical end, at the coronal end, it had two walls. At the apical end, it has three walls now. Which all are those three walls? Same thing. The distal wall extending down, the lingual wall extending down, and suddenly you have a buccal wall also. Okay, so now you have three walls there. So it becomes a three-wall defect. Yes, the facial wall. You have three walls there. So now it becomes a three-wall defect. So in one defect itself, at the coronal end, you have two walls, and at the apical end, you have three walls. So that is called a combined defect, where it's a combination of two defects. I hope it is clear now. Okay. Okay. Now moving on to the next one. Okay. So the next in your definition is the crater. Crater is nothing but a cup or a bowl-shaped deformity. Okay, bowl-shaped deformity. But what is it different from the intra-bony defects? It involves two adjacent teeth. It involves two adjacent teeth. That is why it is called as a. Crater, but not classified under intra-bony. So if I draw a picture here to make you understand it. Okay. This is one tooth here. This is one tooth here. This drawing is not that good, but this is the crater that I'm drawing. Okay. So now what are we talking about? This defect or this bony defect is communicating with this tooth, and it is communicating with this tooth. So here there are two teeth involved. Here two adjacent teeth involved. Two adjacent teeth involved. That is why it is called as a crater. And it is cup or bowl shape. Mostly seen in the interdental regions in the posterior teeth. Mostly seen in the interdental regions in the posterior teeth. Whereas see our intra-bony defects, it is affecting this tooth here, this tooth here, this tooth here. This one is protected. This one is protected. This one is protected. Adjacent tooth is protected. Whereas in crater, both the tooth surfaces are involved. That is why it is separate from an intra-bony defect. Why? Because it involves two adjacent tooth surfaces. It involves this tooth surface and this tooth surface. Okay, I hope that is clear. Okay, very good. So that is the different types of bony defects that you see, and how to identify them. Okay, very good. I've got a yes. Okay, so next.